Good morning and welcome to this author interview for the HRO2 Journal. I'm Jeanne E. Poole, the editor-in-chief. With me today is Dr. Uma Srivatsa, the section editor for our Global Voices section, and our guest, Dr. Luis Aguinaga from Tucumán, the CIAT hospital in Argentina. We have had the privilege of a paper being published written by him in Heart Rhythm O2 that highlights the very important early contributions of Argentinian electrophysiologists to the field of electrophysiology. This is part of a series of My Country contributions to electrophysiology. So we're very, very excited, Dr. Aguinaga, to have you here with us, and welcome. Before we get into asking you some questions, which is our goal for today for sure, I would like to just take a moment to set the stage by saying a little bit about Global Voices. In this initiative, it is our goal to bring science from different parts of the world and as well to provide a place for practicing electrophysiologists to share their experiences and also their challenges practicing EP and medicine in general in their home countries. So again, welcome. And I would like to start off by asking you to talk a little bit about the early electrophysiologists and their contributions to our understanding of the conduction system, because to me, this seems very foundational and transformative. Maybe you can just summarize a little bit about that history and what you think is important.
Thank you. Thank you to everyone, and specifically to Heart Society for inviting me to this very important discussion, interview about this paper that we published together with my partner, Dr. Elisari from Argentina, about the main contributions to the history in electrophysiology. And specifically, I would like to comment about the contributions in the conduction system alterations. As you know, in the early 60s, at the beginning of 60s, it was a confusion about the main concepts in the conduction system. The general concept was that the conduction system was bifascicular, just one and two fascicles going to the ventricles, one to the right ventricle and one to the left ventricle. But Dr. Rosenbaum was one of the pioneers of this Argentina school, observed that in some patients have different electrocardiograms that not match with this idea. For example, in patients with right-bundle branch block, sometimes have the axis going to upwards, and sometimes in the same patient with right-bundle branch block going to the right, downwards. This alteration was impossible to explain with the model of bifascicular system. And he thought that more than a fascicle could be implied in the left ventricle. Due to that, he described the possibility to have two fascicles in the left ventricle. After that, several experiments confirmed this hypothesis, and was born the idea of EMI blocks in the left ventricle. Posteriorly was confirmed anatomically and in vivo and in vitro experiments that two fascicles were in the left ventricle, and the new concept of trifascicular system, conduction system in the ventricles. It was a very original idea and contribution to this school. Let me comment that the Argentinian school have made a lot of contributions in electrophysiology, but this specific school that came from Buenos Aires, the Hospital Ramos Mejia, was the school that most contributed to the knowledge of EP around the world. And I would like to mention to Dr. Mauricio Rosenbaum, to Dr. Marcelo Elisari, to Dr. Pablo Chiali, in and enter the most of investigators of that school.
What I think is so interesting, and then we'll switch over to T-wave memory. I just wanted to make a comment that what I think is so interesting is this all started by observations of the electrocardiogram. And to this day, the electrocardiogram, Uma is shaking her head, she's agreeing with me. To this day, the electrocardiogram remains one of the most important parts of our laboratory tests that we have for patients. It has never outlived its usefulness. And continually, we observe findings on the electrocardiogram that lead to the kinds of deductions and investigations that you described with Dr. Rosenbaum and his colleagues at that time that just changed completely our way of thinking about cardiac electrophysiology. It's really amazing, and we're so thankful for the work that was done in Argentina at that time. Uma, I think you wanted to jump in and say something.
Absolutely, Jeannie. I mean, what an important observation that was, not only for description of hemiblocks, but later on for description of fascicular VTs, intrafascicular VTs, and source of PVCs from those individual conduction fascicles. That was such an important observation, and absolutely ECG paved the way for all this. So on another note, Dr. Aguinaga, I believe Dr. Rosenbaum also described T-wave memory, right? And that's an important concept, especially in accessory pathways. After ablation, we notice deep T waves and bundle branch blocks, paced rhythms. Do you want to talk a little bit about those concepts and any idea of the description of pathogenesis of these T-wave memories?
Yes, thank you. I completely agree. And one of the causes to write this article was that some people, young fellows, don't know habitually the mechanisms of these descriptions, original descriptions. And T-wave memory is one of them. After ablation, as you commented, after ablation of an accessory pathway, habitually we can observe this phenomenon. And the pioneer of this phenomenon was Chatterjee and colleagues, who described the electrical memory, T-wave, in patients after a ventricular pacing. But this idea was taken by Rosenbaum and colleagues and performed a global description in different clinical scenarios, like VT, PVCs, ablation, after ablation, accessory pathways, and also ventricular pacing. And they explained that the T waves continue after the restoring of the normal activation in the ventricular activation or depolarization in the same orientation of the previous abnormal QRS. Due to that, they mention or call that electrical memory or T-wave memory in this phenomenon. It's a frequent phenomenon, and we can see in different forms of different activation in the ventricles, the T-wave memory. And it's important in the clinical scenario because sometimes we can confuse that T-waves, negative T-waves, for example, could be positive or negative, with ischemic heart disease, with another alterations. And it's important to know if the patient has a permanent pacemaker that stimulus not all the time is on pacing, the T waves negatives remains after pacing. Sometimes we can confuse them, for example, with ischemic heart disease. I think that is another important concept for this school.
So when I was a young fellow, that was a very long time ago, I wrote a small paper on this subject, and we were doing accessory pathway, early ablations, and even some patients from prior to that era with surgical ablations. And That was sort of my first introduction to this whole concept of T-wave memory. And I remember pulling Dr. Rosenbaum's, articles to try to understand that mechanism. But it is very important because you're right. I mean, for people who simply don't know, they may think the patient's having some sort of ischemic event. And it's, of course, always a fun ECG observation to point out to new fellows.
Do you have it? Is there a concept as to why it occurs?
Yeah, mainly is due to the alteration of the forces and initial forces in the repolarization after a different activation in the depolarization that remains with different activation. When the activation, abnormal activation, ends, the normalization is possible. Maybe based in calcium inflow in the myocyte. Is one of the theories about this phenomenon.
Yeah, I don't think the exact mechanism has been fully explained, but it certainly is something that happens because we all know that. So we are again appreciative to the early description of this phenomenon. I'd like to sort of go back to the conduction system for a bit and have you talk about the discovery of or the identification of and categorization of blocks, phase 3 and phase 4 blocks. And especially, how that came about, what was the observation that led to that, and then how that relates to kind of the language that we more often use now, tachycardia dependent or pause dependent, and sort of how those groups of investigators came together on what's actually happening here.
Mm-hmm. Yes, in the beginning of the 70s, 1 decade after the first description of the trifascicular system, they started some investigations about this kind of phenomena. Phase 3, phase 4 phenomena are intraventricular blocks, different models, animal models mainly, and in some models are work on patients also. And he described the phase 3 and phase 4. Phase 3, tachycardia dependent phase 3 block, for example, in the intraventricular conduction system, but also after that was described in the AV node or in different localizations of the conduction system. But mainly in the intraventricular system, they show that in some cases when tachycardia occurs, sometimes the next beat can find in the refractory period to the next beat and block occur. And in the other hand, with bradycardia dependent, the same occur in the phase 0 of depolarization. It's impossible to depolarize the next beat and block occur. For example, the majority of these situations are physiological, specifically phase 3, not so frequent in phase 4. But sometimes, for example, in Chagas disease, that there are a lot of models with disturbances in the conduction system, intraventricular conduction system, we can observe two phenomena in the same patient with phase 3 block and phase 4 block in different moments of the activity of the patient.
Interesting. Dr. Aguinaga, thank you for that description. And I want to recognize Dr. Wellens and remember Dr. Josephson, who conducted early, the intracardiac electrogram courses, certainly for their newbie fellows. And I learned these concepts from them, which led to, during the clinical practices, have been very helpful. So you brought up Chagas. Do you mind talking about the early Jessica trial, which originated from Argentina, and predominantly the patients enrolled were dilated cardiomyopathy patients with Chagas disease. And that was the trial that introduced amiodarone in the management or long-term management of ventricular arrhythmias. And subsequent CHF STAT trial did not show a reduction in mortality, but Jessica did. But these two paved the way for subsequent SCUD-HF trial, for which Dr. Poole was one of the prime investigators. So would you mind commenting on amiodarone, the concept, why it was decided to be used, and where does it stand today?
Yeah, okay, yes. In Argentina, in general, we had a lot of experience treating patients with Chagas disease in the one part, and also with amiodarone. From different studies, one of the main investigators was Dr. Rosenbaum and Dr. Elisari with amiodarone in different subjects. But they found initially that the most useful application of amiodarone was in patients with heart disease, left ventricular dysfunction, Chagas disease, to prevent the occurrence of ventricular arrhythmias. And after that, also to prevent atrial fibrillation. And different models in different cardiomyopathies, Chagas, the main cardiomyopathy study, show that amiodarone can prevent the occurrence of these arrhythmias, complex ventricular arrhythmias. And after that, investigators from Argentina started with the Jessica trial. Jessica trial, published in 1994 in Lancet, show that the low dose of amiodarone, 300 milligrams, compared to the just medical treatment in patients with left ventricular dysfunction and cardiomyopathy, the group of amiodarone observed that they can reduce the mortality and also the admissions due to heart failure and different endpoints, secondary endpoints additionally. And was the first study, randomized study with, they included 500 of patients that show these results. And also show that amiodarone is safe and the safety and efficacy of amiodarone to prevent this kind of ventricular arrhythmias. But this initial observation was not confirmed in the trial, the following trials that you commented, that SCUD-HF or different trials. And there are a lot of reasons, maybe different pharmacologic treatment of heart failure, different type of patients included. In our group have more patients with Chagas disease, not just with heart failure for ischemic heart disease or another cardiomyopathies. But it's interesting, up to now, amiodarone continue being an useful pharmacological treatment. And in that kind of patients, for example, with heart failure, in the majority of countries in Latin America, is the unique pharmacologic treatment that we can use in this kind of patients. We don't have dofetilide, for example, it's not available here. And we can use just one pharmacological treatment that is amiodarone in that kind of patients.
Yeah, interesting. Interesting you brought up that. I mean, amiodarone is here to stay, even though it didn't reduce total mortality. It definitely helps improve arrhythmias, leading to further now escalation trial, and that brought the concept of even introduced ablation, both in atrial fibrillation and VT ablations in CHF patients to improve clinical outcomes. So I think we are kind of coming to the end of this interview. Jeannie, do you want to?
Yeah, I was just going to make one last comment about that, because again, as being a SCUD-HF investigator, I just again have to thank Argentina for having that Jessica trial. I don't know that we could have showed equipoise. in terms of providing the background to doing that trial. So it was so important to do. And I think your point about different kinds of patients is probably a really critical point. We didn't have Chagas disease patients in Scott-Heft. We had ischemic and non-ischemics. And then and it was a little bit different too, because these were not patients that had to have any kind of ambient ectopy, and they certainly could not have had any prior VT or VF. So that probably also sets them apart from Chagas. And especially the New York Heart Association Class 3 people are the ones that demonstrated the most profound lack of effect of amiodarone. But you're right. I mean, amiodarone is our go-to drug. We try to use other medications, and we are fortunate in this country to be able to first try other medications, dofetilide, dronedarone. We have all of these other options, but oftentimes as patients go along in the course of their heart failure, especially if they have a lot of arrhythmias, we use amiodarone to suppress them, to be able to get them to the EP lab and do ablations. So we are eternally thankful.
Yeah, absolutely. Jeanne, on that note, would you mind if I ask Dr. Aguinaga, so in Chagas disease, you have the most experience in managing Chagas patients. Is conduction block a more important problem, or ventricular arrhythmias and heart failure more important problem? What do you see most?
Yeah.
Practice patients.
Yes. It's good. And some patients have the two abnormalities. Sometimes it's very difficult to know specifically. For example, we have a patient with syncope and Chagas disease, and we studied the patient, and we habitually found both alteration, blocks and ventricular arrhythmia. And sometimes it's impossible to know which specifically was the phenomenon that caused the syncope. But yes, the main alteration in Chagas disease are blocks. The Chagas disease started with alterations in mainly right bundle branch block and ME blocks, PR prolongation. And after that, in the time on the history of the patient occurred ventricular arrhythmias at the end of the heart failure. After that, aneurysms occur. In patients with left ventricular dysfunction, severe, can occur more ventricular arrhythmias. But in the majority of the patients, we can observe both phenomena, blocks and ventricular arrhythmias.
All right. Such an interesting disease, possibly a lot because we just don't see a lot of it in the US. But I think we've come to the end of our time, and we've had a wonderful discussion. I want to again thank you so very much for being with us today, and most importantly for writing and publishing your paper with the Heart Rhythm O2 Journal and highlighting all of these great contributions from the Argentinian School of Electrophysiology, I think is as you referred to it. I'd like to thank Uma Srivatsa, our section head, for being with us today, and thank all of those viewers out there who are going to be listening to this, and hope you really enjoy this webcast today. It'll be one of a series of similar topics. So with that, I'm going to wish you all a great day and bid you goodbye. Thank you.
Thank you. Thank you so much.